Hi.
Hi, everyone.
Hi.
Hi, everyone.
I think, yeah, it's working. You've put the recording back on. Yep. Let's just wait 1 minute and then let's go. There are people joining, but just 1 extra minute, we can start. Yeah, should we go ahead? All right, well, welcome, a very warm welcome to everyone who's joined us today for this webinar. My name is Natalie Drew and I work in the Policy, Law and Human Rights Unit of the World Health Organization, and I'm based in Geneva. So as many of you by now know, this webinar is the third in a series of webinars that we're running on throughout the year, looking at different aspects of creating mental health systems and services that do not use coercion and that really promote a rights-based and recovery-oriented approach. And the purpose of today's webinar is, in fact, to really zoom in on the practical aspects of implementing a recovery approach. So the recovery approach has been championed by people with lived experience since the 1990s and has really been instrumental in actually promoting human rights in the area of mental health. But recovery itself isn't considered a human right explicitly, but nevertheless, both recovery and human rights have a number of common principles, including, for example, the need for a transformative move away from a biomedical model and towards a supportive model or approach that really values diversity, autonomy, connection, community inclusion, and so on. So recovery basically means supporting people to find meaning and purpose in life, whether that could be through their work, through educational opportunities they might want to pursue, through their relationships, community engagement, and other meaningful pursuits. But despite the sort of increased recognition of the importance and the usefulness of the recovery approach, there's still quite a significant gap in terms of its actual implementation in practice, in services, and on the ground. So that's why we're really pleased today to be able to have with us two very different examples of efforts that are being undertaken in very different contexts, in fact, but both trying to introduce recovery approaches, recovery planning within services. So we hope you will use this webinar to really dig deeper into the issue, to ask questions, to share your own experiences. And the idea really with all of these webinars is that they be dynamic, interactive, and that you really participate, everyone, the audience, the speakers, all together. Another thing that I just want to mention is I would encourage all of you to do the Quality Rights e-training, which you can actually find the link to in the chat, and I will add the link also at the end, because basically this gives you a foundational understanding about recovery-oriented approaches in mental health. So I think that's a very useful activity to embark on. Doing the e-training will give you that sort of foundational knowledge and yeah, to sort of deepen your knowledge on these areas. In the chat, you'll also find other useful resources. So there'll be WHO information, more information about the Quality Rights Initiative, but you'll also find the links to our training resources and tools on recovery, but also on other aspects of ending coercive practices. So do have a look through those as well. I'd like to thank our moderator and our speakers for being with us here today to share their experience and their expertise. I'm going to now hand over to Dr. Gregory Keane, who will be moderating the webinar. Greg, let me just give a little bit of background about Greg. So Greg is a psychiatrist and a health service strategist working in the general community and at-risk populations internationally. He has experience working with Indigenous peoples, with vulnerable communities in urban settings, with refugees and displaced people, and also with military veterans with mental health difficulties. He spent 10 years working for Doctors Without Borders as a clinician, as a technical advisor, as an MHPSS researcher, with various different projects, MSF projects, including in countries like Iraq, Afghanistan, Gaza, the West Bank, Yemen, Jordan, and parts of West Africa. He also has a strong interest and involvement in developing WHO quality rights approaches, specifically in the humanitarian context. So over to you, Greg. Thank you very much.
Thank you so much, Natalie. Thanks, Natalie Michelle, for having me here today. I'm very excited to be here for this fantastic topic on recovery. We've got a very interesting range of speakers for us today, and Natalie's given us a brief introduction on recovery. So I'm going to introduce the speakers and then move into a short introduction before we move on to introducing the first presentation. So if people do have questions, please raise your hands rather than putting the question in the comments, though you can do that too if you want, though we might miss you. To start with, I'd like to introduce the speakers that we're going to have today. First of all, Peter McGovern. Peter is a psychiatrist dedicated to developing rights-based approaches to mental health and supporting people with psychosocial disabilities. He's a consultant psychiatrist at Modum Bard's Trauma Polykliniken in Oslo, Norway. And he has a special interest in psychoanalytic psychotherapy, as well as systemic approaches to understanding mental health conditions. Peter's a key contributor to the development of the WHO quality rights guidance and training tools, and he continues to work with WHO as a quality rights consultant and trainer around the world. And joining Peter today is Jan. Jan was a member of one of Modum Bard's recovery groups in 2023, and we're lucky to have him here with us today. He'll share his own experience of being part of that group. Thank you, Jan. We're also fortunate to have with us today Jacob Shamurarira. He's a person with lived experience from Zimbabwe who struggled with substance use disorder. And after recovering, Jacob has set up a non-profit organization working in mental health and is playing a leading role in the promotion of quality rights and other mental health interventions in his country. Finally, we have Alexei Kostyuchenkov, who works at the WHO country office in Ukraine, and he's been supporting efforts there to introduce recovery approach and recovery planning within community-based mental health teams in the country. So welcome to you all. It's fantastic to have you all here. So what I'm going to do is jump straight in and ask Natalie to share a very short slide of introduction, and I'll go through that with you now. Thank you, Natalie. So as a brief reminder for everyone, a recovery plan, first of all, is a user-driven document, definitely not clinician-driven, that is created and implemented by people themselves. And the plan can obviously change over time to reflect the person's own recovery journey and their preferences as they evolve with time. And people can develop the plan with other people in consultation with others if they want. But what's really essential, what's so crucial about this is that people themselves are the ones who decide what they want to include or to not include. So to get started, the tool we're going to be talking about today is person-centered recovery planning for mental health and well-being by a quality rights team. And I'll just be calling it the tool today. The tool takes people through the process of how to develop a recovery plan. And it covers 5 areas that are shown here. Planning for pursuing dreams and goals, a wellness plan, a plan for managing difficult times, which is so important, for responding to a crisis as well, and what to do after that crisis. So very much a holistic approach. Thanks, Natalie. Can we move on to the next slide? Thank you. So that first part, the plan for pursuing dreams and goals. So a key component in the creation of a recovery plan is a plan for someone pursuing their own dreams and goals. And as a first step, the person is going to identify their dreams and goals. Some people, it might be a big dream. For others, it might be small things. And dreams can be about really specific things that people want to achieve. For instance, getting a job, doing volunteer work, maybe finding friends to share hobbies with, or something as simple as reading a book or making some art. And then the person will identify those specific steps to achieving that goal, or those goals and those dreams, and really thinking about what are the person's strengths, what are their interests and their capacities, and what are those those strengths and capacities of people around them that can also help them. So very dynamic and very much about what the person wants to achieve in their own life. Natalie, can we have the next slide? Thanks. Right. So the next thing is a wellness plan. So how do we put that into place? And we're going to hear a lot more about this from Peter and Jan later. It's about helping to identify routines that help keep people well, and also those things that might have a negative impact on mental health. So positive routines, things like eating healthfully, eating at regular times, doing exercise, walking, and then thinking about what are the negative routines that also might make that a bit more difficult. Things like sitting around and doing nothing, maybe using substances as well. And so thinking about what is the balance of my wellness. Natalie, thanks. Obviously, very importantly, sometimes when people are suffering mental health difficulties, they come through difficult times. And planning in advance for those things, even though we definitely don't want them to happen, is really so helpful. Thinking about how to deal better with your own emotional distress, and how to identify those sensitivities and signs of distress. And sometimes identifying those sensitivities means that we can take action much more quickly when we've got distress. So that can really reduce the chance, if you know what those things are, of finding yourselves in a crisis. And then also thinking about who you want to share that with, and for other people around you who care about you and support you and who you trust, to be aware of what those sensitivities and signs are, so that they can discuss with the person who they're supporting if they see those things with their permission. And then the fourth thing is responding to a crisis. So plan for responding to a crisis allows people to provide directions on when and how and where and from whom they'd like to receive support. And also allow specifically people to specify no to certain treatments. So very much this is what the person wants, and also specifically what they don't want, based on possibly on experiences that they've had before that they weren't happy with. And that's very empowering. And there might be also several things that the person might want to be taken care of if they were going through a crisis. For instance, maybe you have a pet who's going to look after the pet. Perhaps you have some bills that you're not going to be that are going to be outstanding, or you might have a regular appointment that happens for you, and you'd like someone to help you to cancel that, or to let someone else know that you won't be attending. So really about empowering you and removing during that crisis things that might stress you, or things that are really important to you that can help you. And then crucially, it allows people like myself, mental health clinicians, to really understand and support someone better. And so we can make sure that we respect the person's will and their preferences in that crisis. And this is definitely about a recovery journey. So what about after the crisis? And it's really about helping people get back to their daily life and maintaining wellness after that. So what are my routines? What are the things I'm going to be doing in the next days to weeks? How do I step back into the things that that are important for me to do in my day-to-day life? And really crucially, again, what have I learned about myself and about this and about what I want in the future? So what we're going to do now is move into that's pretty much it for the presentation, just to summarize that for you. And I'm going to ask Peter and Jan to jump in with their presentation. Thank you.
Yeah, thanks so much, Greg. So really lovely for us both to be here. Jan and I have agreed that I'm going to start a little bit and maybe introduce more of the structural aspect of how we got these groups going and what they actually look like in practice. And then Jan and I are going to have a bit of a conversation about what it was actually like to go in our group. So I, as was said in the introduction, I work in a specialized trauma center. One of the things that I feel quite strongly about from my professional background is that I don't think that the stuff that's in quality rights, the stuff that's in a recovery approach and a human rights-based approach, I think it's not just an important ideological and paradigm shift for all mental health services. I feel very strongly that this is a really important and quite transformative clinical tool as well. And that, I guess, was one of the things that led to the creation of our trauma-orientated recovery planning groups. We kind of, I personally have been using the recovery plan for quite a few years, but we wanted to kind of operationalize it and make it a kind of central part of our support offer here at the trauma clinic. So what we've done is we've used the quality rights recovery plan and turned it into a group-based program. So we have an 8-week group, which we call our TORP group, so the trauma-orientated recovery planning group. Where 9 people, together with 2 facilitators, have the opportunity to create a recovery plan for themselves and share the experience of creating that recovery plan in a group format. So we're talking about twice a week sessions. So we have a physical session that's around 1 hour, 15 minutes. And then we have a digital check-in session that's about a half an hour, slightly later in the week. And quite quickly, this became a very popular approach and something that people felt was quite useful and effective in helping and supporting them on their recovery journey. One of the interesting kind of clinical overlaps here from my point of view is that often in trauma, people that have experienced difficult things in life, there can be a certain amount of avoidance behavior that can build up around difficult things that can happen. People describe to us quite regularly that they feel trapped in a pattern where the same things happen over and over again without having the opportunity to really look at that in what we call peacetime, when things are actually going pretty well, to then make a bit of a proactive plan. Think about how can I deal with difficult times in a little bit of a different way. Who do I have around me in terms of my support network? Who shall I give which role to? And not least, to have the opportunity to be together with other people that maybe have similar experiences, similar life experience, similar lived experience, to kind of share that approach and use each other as a resource. And that is that's so really we divide up the plan over the course of 8 sessions, and we work with it quite actively to build a plan. As Greg said in his introduction, this is not something that I, as a clinician, drive or have control over. This is something that we're very focused on making sure that people realize that this is a different type of document. This is a document that we want people to have ownership of themselves, that they're the ones that decide what they do with the plan, what it looks like, what's included, what's not included. We've had everything from people that use the plan and follow the kind of WHO plan after the letter. We've had other people that have used it as an opportunity to have some important conversations around planning for the future and planning for difficult times and focusing on goals and dreams they have. And we've had other people that have interacted with the group in a much more creative way, that have written poetry, songs to try and encapsulate that recovery journey and what they're trying to do. So we really encourage people to have as broad an interaction with it as possible. One small thing I'll also kind of add in that's maybe different since Jan has took the course last year is we've now also allowed all participants to take the Quality Rights e-learning course in addition to the group. So we really wanted to kind of build up that basic knowledge on recovery, the human rights approach, and that's something that's proved very popular and quite empowering for people as well. So I'm really delighted today that Jan was willing to join me and be along with us today. And Jan, as Greg said, you took the course about a year and a half, a year ago or so. First of all, welcome, and second, I just wonder whether you'd like to say a little bit about what it was like to go in the recovery group. What was your experience of it?
Thank you, Peter. For the first sessions, I felt it quite difficult because it was a new experience to go to a course that changes from the normal learning from the teachers to give us something. While this time it was we who's going to give to ourselves.
Yeah.
So that was a little bit journey at the start to start to see me as a resource in my own life.
And I remember, Jan, we had a lot of conversations in that group about how different that was. There was almost an expectation in the group that something would be given out or the answer would be given. And it took us some time as a group to really work with that idea that the answers and the resources are already there in us. I'm curious as to what you think. What was different about that approach compared to maybe other things that you've been involved in the past, or what struck you as new or important?
It was our own possibility to talk in the group, learn from each other, and we were also quite different, so we could get different perspectives of things that are happening in our life and how others are tackling them and how they want to go further, so we can learn from each other.
Yeah. And that was something that you and I have discussed quite recently together, Jan, that you felt that it was kind of a strength almost to do this as a group project, to kind of be together with other people with different perspectives. And I remember you said that it's not always that we've got the answers ourselves, and it's kind of a positive to hear experiences and solutions and things that help in other people's lives, that was a bit of an inspiration for you as well.
Yes, it was. It made the group to attend there was got more easy when we could use each other and talk and learn from each other. And when we should start to make those different plans, it was nice to hear other people put their words on maybe things I struggle with. So, but you don't always see it yourself, but when you listen to others in a group and you have a similar goal, it was a great experience.
And would you mind, Jan, saying a bit about like how the recovery plan or the group process, how that helped you personally, if you have any reflections on that?
Yes, one of the things that was important to me was to look at the resources around me and how I could use them. And I found out that I needed to do some changes to this group, because when I needed help, I'm not always used the right ones. So it was a learning from me, and that made me do some changes. For my own life, it was also good to put myself as a resource. I'm not used to that.
Yeah.
I'm used to just say, okay, that's life, and I'm not good enough or something. But to go to a group and working with being a resource in my own life, it was very helpful.
And I remember that being quite a big topic for the group as well, that it was almost unusual and refreshing to have that focus on the resources I have, the kind of idea of changing the narrative around ourselves, and also being able to make sure that our voice is always heard and our will and preferences is something that's actively communicated to people around us. I'm aware of time, Jan, that we've got kind of limited time left. But one more question I was just curious about was whether you kind of thought that recovery approach, that more resource focused approach, whether that maybe has a role more broadly, or something that you personally would like to see more of, or any thoughts on that?
It made a difference in my life, and it also went to mention that we went to a summer break in my course, and we had the experience to come back after 4 weeks and tell each other how our plans went, and we could learn even more from each other. And I've been using my document also for this presentation, how I could get some help around me, use the resources that are in my life.
And I know we've talked a bit about that, even though that this is quite a, for all of us probably a bit, we get a bit nervous in a big presentation, and that you were kind of actively using your support network and actively planning about how you can take some positive risks here, but also use the resources you have around you in a positive way.
Yes. So it made me come here today, and it was, yeah.
That's great. I know we're out of time, Greg. I kind of pass it back over to you. I could talk all day.
Yeah. It was an absolute pleasure to have you here. Thanks for your courage and for sharing. And I really, a lot of people have commented, have put in the comments, and I wrote down as you were talking about being a resource in your own life and a resource for the other people in the group. And I just want to take that message with us today as well. So thank you so much for being here and sharing that that knowledge and that experience with us. I know that I'm going to take it away, and I'm sure all of us are here too today. So thank you. What I'd like to do now is actually move to you, Jacob, and ask a question. Jacob, do you think this is something that could work in Zimbabwe, and what would need to happen to make it work? What's your thoughts?
Right, thanks, Greg, and thanks, Jan, for sharing your experiences. So, yeah, looking at Zimbabwe, a few years ago, trying to implement some of these interventions would have been quite difficult and a huge task. But since the coming in of the Special Initiative for Mental Health, a lot of opportunities have been presented in terms of rolling out some of these useful interventions. So yes, I would say it is something that we can do, something that can be done in Zimbabwe. And there's so much in terms of the human resources and organizations working in Zimbabwe that present an opportunity for us to bolt onto it. So I just want to touch on a few of those. For example, the service providers, quite a lot of mental health skills are being delivered through the MHGAP intervention. So we now have a bit of understanding on how to deliver mental health interventions, and the quality rights e-training has been rolled out to a lot of service providers. Then within the service user community, there is a growing network of people with lived experience who are coming together to share their experiences and knowledge on how to prepare for a crisis, know much more about the quality rights, know what the triggers are and how to mitigate a crisis when it starts. So the community sensitizations are quite helpful as well in reducing the stigma that used to be a huge problem around mental health. So with the reduction of stigma, it then gives people with lived experience like myself and others and current service users to have more courage and resilience and be bold enough to say, this is how I'd like my recovery plan to work out, and obviously working in consultation with their family members, members of the community, and the service providers. So in short, yes, it is something that can be done in Zimbabwe. The scope for it is there. And I think what really needs to be done is just to scale up and step up some of the already existing interventions, such as the community nurses. There are nurses in the community who can help to follow up on the different interventions that are being done. So yeah, that's my response to our perspectives from Zimbabwe.
Thank you so much. What I'm going to do is open up the audience and see if people have got any questions. So put your hand up if you've got questions that you'd like to ask Peter, for instance, Jacob. In the meantime, I'm going to ask a question, and that is, I guess one of the things, Peter, that I often hear from people is we don't have the time for something like this. I mean, I've got lots of answers that I might give to people in response to that, but I wonder what have you said to people in this implementation process when they've said something like that to you?
Yeah, I think that's the beauty in many ways of the recovery approach, that this can be done in so many ways. It can be done in a kind of a more structured way that we did in our clinic in a group format, or it can actually be started by people with lived experience themselves. I know people that work actively with these recovery plans. I also kind of think that recovery planning and the kind of supported decision-making aspects and the future directives aspects here, this is a time investment that saves a lot of time and effort at later dates as well. That's why I'm so focused on it as a really useful clinical tool. I think if I'm supporting someone, if I'm working with someone, the most important information I can get from that person is, how would you like to be supported if things get tough? What can I do that can help, or what can I avoid doing because we know that doesn't work or that makes things worse? You know, I see that as a rights issue, but I also see that as a core good clinical practice issue as well. And I think really not having time to give good clinical care and good support, that's usually not an excuse that flies anymore, thankfully.
Fantastic. Thank you for that. We do have a couple of questions so far. So Ishil, I wonder if you'd like to voice your question that you put in the comments. Please feel welcome. I'm not sure if Ishil's there. I might just ask that for Ishil. Was therapy group a substitute to individual sessions? Was one of the questions that was asked.
Good question. Yes and no. It kind of depends. Some of the people that would have gone in the group, they would have individual sessions in addition. And other people felt that they were perhaps finished with individual therapy and wanted to have this focus exclusively. Those people that did have individual support, you know, that could be any type of therapist or supportive person, they were usually encouraged to share that plan and to share the process and involve people as much as possible. We've had a big request from the last few groups that people want to involve family members even more, and we're thinking about how we can actively involve support players even more and kind of draw them into the process in an even more concrete way.
Fantastic. So, like, you know, I mean, what I'm hearing is that the process that you're developing is quite organic in a way. It's really responding to what people with lived experience, with what people are saying that they want, and I think that's exactly what we should be doing. It's the essence of recovery. It's person-centered. Olga Kalina, one of our quality rights experts, who's also in the audience today. Olga, you had a question. I wonder whether you could speak that to us. Would you be able to join us by voice?
I have practical question because we have similar activity in Georgia, and I'm just interested how you are doing it in your group sessions. Are participants supposed to develop recovery plans or parts of the plans during these group sessions, or are they like using these group sessions just as preliminary activity to discuss things and later then they develop plans independently from the group? Because sometimes people have some, you know, confidential or individual issues that they may not be ready to share readily in the group. So maybe you can elaborate on that. Thank you.
Yeah, great question, Olga. So again, the kind of yes and no answer there. One thing I'm quite clear about in the groups is it's not that, again, I feel we have to move away from the fact I don't have an expectation that people do their homework or that people do the plan and get to the point that the plan is totally done. I'm very happy that if people are just at the group, use it as a source of inspiration, and then maybe perhaps work with a more concrete plan at a later date. There's some people that do that. There's some people that work with it quite structurally during the course of the group. The most important thing for me is it's the person themselves that decides how they interact with the material, how they use it, and how much they want to share. We have some kind of rules for all our groups. We tend not to share too much kind of information that can trigger about past experiences or past traumas. We try to hold our focus to the here and now. And some people share quite actively what's in their plan, and other people kind of keep that a little bit more private and don't want to share it and talk more generally around the themes and some of the quite existential themes that kind of come forward through the plan.
It's very clarifying. Thank you very much, Peter. I'm going to move to someone in the audience, Renu Varun. Renu, would you like to ask your question, and then I'll move on to Michelle.
Yes, hi. Thank you, Greg. And thank you everyone else for allowing me this opportunity. I have put something in the chat as well. I'm from India and I currently live in Dubai. So we have been working in the space of prevention of suicide for the last 25 years. And somehow, you know, it's, as I mentioned in the chat, it's a bit like mentioning, I mean, we just take an analogy, an example of Harry Potter, somehow to point the time, drive the point home, right? I'll just share a very quick statistics with the group. And that's where my question sits. You know, in 2021 in India, the number of deaths by suicide were more than the number of deaths by road accidents. And the 2022 figure is also the same. I mean, if it's not more, that is, because suicide is hugely underreported. Having been in the space for last 25 years, the challenges, of course, is the stigma, the silence, the financial constraints, the free assistance expectation, you know, that's like an epitome of working in the social sector. And then the lack of understanding around suicide. So these are, you know, very realistic challenges that we are facing in Southeast Asia, you can call it the, you know, you can call it the low and medium income countries. I mean, whatever title that you want to give. And now, however, we are in the space for 25 years and there is no looking back or kind of feeling defeated or discouraged, because this is what we live for. Talking of the wellness plan, you know, we have recently designed a wellness plan. We call it My Wellness Plan, My Wellbeing Plan, and we are getting it translated in, I think, we are trying to get it translated into all African languages and Indian languages. But yes, the perennial challenge that we face, and this is where I would really want to know, how do we bridge the gap between the stigma, the financial constraints, the support from the government, right? Because the moment we are going to the agencies, they are it's not a priority. Like, for example, in India, the mental health budget is 1%. And
Renu, I might just jump in and ask, if we can move on to the question, because I do want to catch another couple of people.
Yes.
You were kind of summarizing that you were asking a question about, I think, linking, I guess, you know, in terms of budget and time and how we achieve all of this at the same time.
And also equally on the awareness, you know, because the stigma is another huge deterrent and impediment. So looking at all these factors, is there something that we can look forward to in 2024 moving forward?
So I might jump in and answer that and say, look, I think recovery is a tool that it doesn't actually cost anything to implement necessarily. It can be developed and delivered by people who are going through their own recovery journeys, who can start their own groups, for instance. It doesn't need clinicians. It doesn't necessarily need a budget, though, of course, that would be, you know, way, way better. And so if I had a hope for 2024, it would be that more mental health services supported that. Peter, anything you wanted to add?
No, I think it's exactly that. I think that's something that's so stuck in the narrative around mental health, that in order to change things, we need more clinicians, more psychologists, more psychiatrists. I don't think that's the case. I think we need to get the voice of people that actually know what's best for them more forward, and that doesn't necessarily need more money. That requires a culture change, and I think that's where the progress will be found, really.
Thanks, Peter, and Renu, thanks for highlighting those important issues. Michelle Funk, can I ask you to your question, please?
Yes, thank you so much. I thought it was interesting, the comment before and the distinction between the individual sessions that can happen and the group sessions. But actually, I think what's maybe even more important is what is happening in terms of maybe the traditional treatment approach in the service versus this recovery approach, and how do they interface? Because ideally, it should be the recovery plan in which, you know, the traditional ways of thinking about treatment are integrated, whether it's medication, other forms of therapy. So I'm interested to hear your thoughts on that and how they can get integrated.
Yeah, 100%. We're a smaller service, so all the clinicians are kind of cycling through, leading the recovery group. So everybody's kind of getting that build up of the knowledge around recovery and around human rights based approaches. But we're also including aspects of recovery and definitions around recovery and the new way of thinking around mental health in all our groups. So that's something that we've been trying to integrate more widely. And I would agree that really it should be the treatment options that are built in around a person's recovery plan, rather than the recovery plan being a kind of add-on or a stick-on extra. And that's something I think that perhaps has to happen at a wider system level, but also in the way that clinicians talk about these tools and talk about their usefulness and how they should be used. That this is the document from which everything springs, not something extra.
Thank you so much for that. It was really wonderful hearing some of these creative ideas about adapting and integrating recovery approaches, and as Michelle said, making them central to the approach that's taken in support and care and on people's recovery journeys. What I might do now is move on to our next speaker, Alexei. Alexei, you're going to discuss actions in Ukraine. I wonder whether you're ready to start. Thank you.
Yes, thank you, Gregory. Hello, everyone. I'm happy to see all of you. And I would like to share with you some of Ukrainian experience. I will start from small history dive. So before the healthcare reform, which was started in Ukraine in 2016, psychiatric care was provided through inpatient and outpatient services, and the network of these services was quite extensive. Despite that, often people hesitated to seek help for a long time due to the stigma and reported human rights violations, which was associated with psychiatric care. So when a crisis unfolded, a person was usually hospitalized to inpatient departments through emergency services. So in this inpatient department, people received intensive treatment with a focus on pharmacological treatment and often associated with coercion. The primary focus of the treatment was on a disease and on symptoms. After discharge, the person was referred to outpatient service, where support was continued to be on symptom management. So in this extensive system, the one core element was missing. It's a person with the resources, with capabilities, strengths, and potential. Since 2015, the WHO has supporting local authorities by introducing a new service. It's mobile community mental health teams. Starting with 4 teams in 2015, there are now 86 such teams which functioning across the Ukraine. From the very beginning, the recovery approach was placed to the center of the mobile community mental health team service model, and the quality rights training materials was used for the education. Of course, there was a resistance from mental health specialists in the beginning, mostly due to misunderstanding and their big experience in other services. Changing the culture and attitudes anyway takes time, and it doesn't happen in a moment, in a week, and even in a month. You need to invest a lot in capacity building and training and supervisions, etc. The quality rights person-centered recovery planning self-help tool helped a lot in this process. It conveyed the new and complex essence of recovery, explained in simple and practical and applicable language for both people receiving care and care providers. Anyway, without a practical tool to implement it, specialists would continue work as it was before. So the recovery journey we have undertaken in recent years has led to an incredible change in mindsets of psychiatric staff. Specialists who have gone through this process will never be the same as they was before. We often hear that they do not want to return to other service models they were engaged before. Now they collaborate with the person for their recovery, being driven by person's wishes, goals, dreams, and preferences. Instead of simply prescribing a treatment plan based on a spectrum of symptoms, as they actually did before, they now start by asking a person what they want, what their needs in their life overall, and what would help them to feel better. The team specialists help person to identify the strengths they have and mobilize them to achieve their own goals. The team now sees not just illness and symptoms, but the person in all aspects of their life. This new broader perspective has allowed healthcare providers to offer assistance that is much more than just pharmacological treatment and covers many areas of person's life. And for the first time in their life, people using psychiatric services have begun to feel that they are not that they are at the center of the process and even drive it. They regain hope and vision for the future. Together, the person and the team work as a single mechanism to find ways out of crisis situation and achieve recovery. The recovery approach has started to create small miracles for each person and for such teams. I think I will stop here and I will ask to play the video which shows the work of one of such teams.
Хворобу склалося, сама не знаю, як склалося. Була я в Італії на заробітках з чоловіком. І у 2005 році стався приступ, такий сильніший.
Вона бачила Бога, з такого більш релігійного характеру в неї були марення, маячні ідеї були.
Ми викликали нормального врача, нічого не знайшов, а психіатрія, мене положили в лікарню, і я 2 рази лежала в Італії в лікарні. З такою хворобою легше вдома, набагато. І ми переїхали сюди на Україну.
Вона, значить, за останніх півроку 2 рази вже лежала в лікарні, тобто ми маємо госпіталізм, часто вона поступає. Наша задача в першу чергу – це не допускати подальших госпіталізацій. Поки що ми з цим справляємося, у неї стан достатньо стабільний.
Дана
пацієнтка чудова яскрава особистість. Вона є працюючою, і хвороба її вибиває з колії. Тоді вона не спроможна ні працювати, ні нормально функціонувати.
У мене свій світ, появляється ще один світ у голові, і я думаю, що я роблю добре, а я вже роблю свої. Я вже живу в своєму світі.
Коли перший раз ми пішли до нашої першої пацієнтки, було переживання, як воно має бути. Це не в стінах лікарні, це вдома, як буде пацієнт себе поводити. Але пройшло все чудово, до сих пір наша ця пацієнтка в нашому сервісі. Дуже задоволена. Ми задоволені роботою, те, як вона себе почуває, як пройшло її, можна сказати, навіть перевтілення. Вона зовсім по-інакшому себе побачила.
В плані відновлення вона писала, для виповнення моєї цілі, моєї мети, треба 100 років.
Ми почали працювати на здивування навіть нам самим. Коли ці зміни пішли, пройшло всього-навсього 1,5 тижня.
То, що не могло статися за 100 років, сталося за тиждень.
Сімейні, бюджетні питання, ми допомогли їм розібратися із деякими боргами. Була проблема у них із відключенням газу. Газ також підключили. Основне – це повернення пацієнта у соціум, щоб зменшити стигматизацію пацієнта. І щоб люди інші також відносилися до пацієнта відповідно. Щоб не казали, що от він психічно хворий, він вже нічого не може. Ні, наша задача все ж таки такого пацієнта повернути назад до соціуму, щоб він не відрізнявся особливо нічим від інших людей.
Посада називається секретар-друкарка. Насправді вона виконує безліч різних функціональних обов'язків. Вона постійно хоче розвиватися, вона постійно щось хоче вчити. Вона підходить до мене і каже, давайте ми зробимо цифрову освіту, давайте ми оптимізуємо якусь мою роботу, пов'язану з комп'ютером.
Я знаю, що наші фахівці отримали шалене задоволення від тренінгів, від семінарів. Дуже хотіли набувати ці навики, вони відгукнулись, вони хотіли працювати, я думаю, що за новими правилами і, сподіваюся, завдячуючи підтримці ВОЗ, тому що навіть ті можливості, які надала ВОЗ, для нас це, повірте, диковинка, ми дуже раді.
Пацієнти хочуть, щоб існував цей сервіс наш. Хочеться працювати в такому форматі, в сервісі цьому мультидисциплінарному. Бажання велике.
Оці мобільні бригади – це надзвичайно потрібна річ, надзвичайно. Хто не розуміє, хто не був хворий, то цього не пойме ніколи. А от хворі люди – це надзвичайно добре, що вдома, в рідні стіни допомагають, як то кажуть.
Thank you very much for that video and the presentation, Alexi. Is there anything else that you wanted to add after the video or reflect on from the video?
Maybe a few words. It's the team from Chernivtsi, and the team is continue functioning. And those lady who was in the video, she feels well and she continues his work. So everyone is fine, and I will stop here.
That's great. Alexi, one of the things that I heard you say towards the end was that you felt that miracles had come out of this approach. And I was reflecting on what that meant or what that could have meant. And I was thinking, in a way, I was reflecting back to some of the words that Jan had shared. And the courage that it takes to start your own recovery journey, and the hope that people find in their own recovery journeys. And in the woman whose story was shared during that video, I did feel a sense of her hope, which is really that essential factor to that recovery journey. So there was also, I guess, I just wanted to also reflect on and, just express a huge amount of I'm just humbled by the huge work that the team have done in Ukraine, building up from such a small number up to more than 80 teams now, and imagining the not just the volume, but also the impact on all of those people's lives in recovery too, the hope and the courage that people have found and have been able to move forward. And also hearing about the clinicians and their changes. And I'm wondering, Alexei, I noticed that there are a couple of comments, maybe some words in the video that we're trying to change, like patient and illness. Are you seeing some changes in language like that to move towards a more person-centered language and more person-centered approaches over time? What's been your experience?
We often hear it across maybe all the teams with which we worked, which we provided trainings, and it's anyway long process, but still we see across all the teams which we trained, all of them change their mind. And it's really a miracle, because even those psychiatrists who had a big experience of work in inpatient services, and they actually was pushed to work in this male community mental health teams. They didn't want to at first. Even they, after complete of education, start to change the mindset, and they worked in such teams with pleasure.
That's fantastic. Jacob, I might actually reach out to you and ask a question while I'm waiting for some other people to ask questions too. So we were hearing about this, this massive upscaling of the recovery approach as a central approach to care, and the change in culture in mental health clinicians and service people. What's been your experience with that culture change in Zimbabwe, just with the quality rights training as a foundation? And maybe could you talk to that for us?
Oh, thanks for that. I remember when we concluded one of the trainings at the biggest psychiatric facility in the country, we had one of the nurses saying, "I feel like I need to make an apology to all my clients because of the way that she had been treating them before getting an orientation on the quality rights." So definitely there has been a change in attitude and practice by the clinicians who have gone through the training. And within the community, since the training has also been rolled out to peer-led groups, community health workers championed by organizations such as the Friendship Bench and the National Association of Persons with Psychosocial Disabilities, we have seen a direct change as well within community-based interventions. So yeah, the quality rights intervention is working and leading to changes in attitudes and practices.
That's very exciting. I mean, it's a foundation, isn't it? That is so exciting. I'm going to jump to Peter soon, but I did see that we have Orest Suvalo who's asked a question. Orest, would you please speak for us? Thank you.
Thank you very much for giving me a word. So it's a big pleasure to be here, and thank you, colleagues from WHO and Alexei, from good presentation. I just wanted to reflect the mobile team issue in Ukraine. I'm a psychiatrist also from Ukraine, and I look at the development of mobile team process launched by WHO, and this very good option that exists already in Ukraine, supported by the state. And this is very important. This is part of the system of mental health in Ukraine, who give additional options to provide services for people. And in my region, I see how specialists are inspired now to provide different type of service, and see how they could be useful to support the recovery of people in communities, as in video, to cover some social issues, to cover some issue with employment. And this is very difficult time for Ukraine now because we are launching and making these changes during the war, and we see also the new challenges which appeared due to the war, to the Russian invasion, and this also one of the options that could be and are helpful for people to recover them, especially during the shelling or after shelling, or working with some consequences of the war for communities. So thank you for this opportunity. And also when we are talking about the quality rights, I think that I like this instrument very much because this is like also the changing of mindset. And this is especially challenging for the post-totalitarian country as Ukraine is, when we are trying to introduce this instrument into practice. And as Alexei said, most of this now in training. And I hope that more people, especially from mental health field, will know about this instrument, will use it. And thank you, WHO, for one more time, because we have already all this instrument translated into Ukraine. And I think that we will work hard to promote this and introduce more in the practice. Thank you for support.
That's beautifully put, Orest. Thank you so much for that. You really highlighted a very important point here, and that is that if a recovery approach and these changes can happen in a country at war, they can happen anywhere. If people of Ukraine can build this approach and integrate a rights-based recovery approach, a human rights-based approach now, then there's no excuse for any of us to miss out on this, for people anywhere in the world to miss out on this. So I just want to, I guess, pay tribute to the huge effort of the team and all of the individual participants in that team too. So thank you so much for that. I wonder, Peter, do you have any reflections on what Alexei had shared about, I guess, about the challenges that that Ukraine is going through, I guess, compared to some of the challenges that you've gone through in Norway?
I really buy into your idea, Greg, that this can happen in a country actively at war at the moment. Then there really is no excuse. And I'm always quite struck by the resistance that you can meet along the way, perhaps in countries with slightly more resources or more political space to implement resources. That there is still a kind of inbuilt culture, particularly in the context I'm in, that the only way to get proper help perhaps is to be admitted to a place. And I think that's a dynamic, a kind of underlying theme, that things like the outreach teams that Alexei's discussing, that really challenges. It shows that actually you can get good help at home where you live, in your community, still being connected to the things that create meaning in your life and that connect you to all those resources that you have inside yourself. And I feel that's another one of the dynamics that needs to change. And I know here in the Norwegian context, we're behind in terms of outreach teams, crises teams, decamping from our clinics and from hospitals and getting into the community to provide support. I kind of feel absolutely essential.
Fantastic. Thank you very much, Peter. I wonder, I'm going to put this question out to the audience, whether there are, I'm positive that there are people out there, people with lived experience, people who are clinicians, who have experience in their own country of scaling up recovery approaches. And if you'd like to have a brief word and share that experience with us, please put up your hand. We'd love to hear from you. In the meantime, I guess I think we will be coming up to the end of our discussion soon. As I said, if anyone's got any questions, that would be fantastic. I do think that that one of the things that I was thinking about before, and I wanted to come back to, was I guess one of the things that you were talking about right at the beginning, Peter, about that people's recovery approaches don't need to be written. You know, a lot of recovery approaches are about lists or about the things that people would do. You talked about artistic approaches, and I just wonder whether you could expand a bit on that, because in a lot of the world, people don't necessarily have the level of literacy that might be required, but they could express themselves in this way, or they might be neurodiverse and they have a different way of expressing their recovery goals or their recovery journey. So I wonder whether I could ask you to speak to that.
Yeah, I mean, again, where that kind of came from, I think is really trying to drive home that message and get it across that it is up to the person themselves how they interact to that. And again, if we're thinking about the supported decision model approach that's kind of central in quality rights and the human rights approach, that yeah, we should be thinking more actively about how we can adapt and grow recovery plans around different models, different ways of making decisions. I think, you know, our experience in the Norwegian context is that creativity is really quite an important way into people's values, their own opinion of themselves, and the ability to express their wishes and desires. That creativity has a massive role to play there, and that's why we've had people that have had art projects, songwriting projects around this, where they feel they've been able to capture something in a much more nuanced, living way through their creativity, and that's perhaps even more easily shared, and that can be used even in a crisis situation. I also kind of an association to I've done a few quality rights training in the kind of some of the Pacific Islands, where there's a lot of talk about collectivist culture and how sometimes that idea of recovery planning, we can fall into a trap where it becomes individualized. And we perhaps have to remember as well that there are other cultures out there that have more collective approaches to decision making, and how we can kind of create space for that perhaps if people want to have a recovery plan that they develop with their family, that they develop with their local communities, that there should also be space for that as well. But again, I think that comes back to implementing, learning from people with lived experience and making the appropriate changes. I think that's often the best way to make sure that all uses of these tools and approaches are receptive to feedback, receptive to change, that we grow and develop them based on people with lived experience.
Thank you, Peter. Very iterative approach. Continue to reflect and develop and strengthen. Michelle, you had your hand up.
Thanks again. I wanted to make, I thought, a comment about the language of recovery, because I think that's really interesting. So we saw and as you mentioned, Greg, we saw in the video the word patient and illness being used quite a bit, and that's not the recovery language, which would be more like a person and so on. And I know you mentioned that. What I find really interesting, and it's just going to take a long time to change, is despite the language, the approach was recovery oriented, you know, the approach being used. And I just think that it's great, you know, for the language to evolve and change over time, but it doesn't mean that recovery approaches aren't being used, even if the language hasn't. And also the converse. I mean, I know that there are services who call themselves recovery-oriented and person-centered, but basically the name has changed, but the philosophy and how they operate has not. And they're traditional, you know, symptom reduction, diagnosis-based services. So it's very interesting, this thing. You can never just go on the title and the language. You've got to look more deeply. So that's just one comment, but just also want to throw a question out there to our speakers, if I may. So, you know, the service in Norway went through its own process, and also in the Ukraine. My question is, you know, if for any other country who wanted to set up a recovery-oriented service or introduce recovery-oriented plans as tools in the service, what are the 5 big, you know, the 5 steps that you must take or you should take to sort of make it all happen, from, you know, maybe convincing the management through to, you know, the more detailed implementation? I'd be interested to hear that, Greg, if we have some time or not, I don't know. Yeah.
Yes, we do. We have time for that, and we'll have time for another question after that too, actually. So we do. Thank you, Michelle. Who would like to respond to that? Maybe I ask Alexei. Would you like to respond to Michelle first?
Well, actually, it's quite difficult question. It's a bit difficult to say that you should do these 5 steps, because it's really huge and it's a very wide process to establish such service. But anyway, it requires maybe mostly a lot of mind changing among different sectors. So maybe you will go after you will answer to questions which what the categories of people should change their mindset first. I cannot say that some of them should do it earlier than another, but anyway, you should be sure that you can cover hospital management, specialists who provide support, people who need this support, and society. So it's close society where the people live. Maybe it's from what we should start. So it's parents, it's relative, and so on. And our work with Mobile Community Mental Health team required to work with these categories of people, and starting from hospital management and specialists who work in these teams. And after that, anyway, these teams is interacting with the people who is receiving support, with their families, their friends, their relatives, and so on.
Really love that description, Alexei, about changing minds and thinking about the different levels. You know, the changing minds of the person themselves, about the way that they see themselves, and that hope and courage I was talking about their families, about empowering them, about their communities and society in general. It's a huge challenge, but certainly achievable, and you've demonstrated that, and Ukraine is demonstrating that in action, as is Zimbabwe. And that level, the clinical level as well, and changing minds there. Thank you so much for that. That's fantastic. Peter.
Yeah, I'm going to try and rise to the challenge, Michelle, and come with 5 points. So the first one I was kind of noting down was use the WHO materials. There is so much stuff in there. It's unbelievable, the stuff that's been gathered over the last 10 years. You can build 15,000 different therapy models around what's already there. So that's kind of, you know, the beauty of the recovery approach is we're not reinventing the wheel. We're doing something that's implicit, that's grounded in human rights, that we've known since the end of the Second World War, that everybody has in them. So that would be my first point. The second point would be, I think, build a narrative around quality improvement and new therapy approaches, because I think that's a language that leadership understand. That's a language that people that are responsible for services understand. They want to give better offers to people. They want to try and meet challenges in different and novel ways. And I think there's so much novel and transformative stuff in the recovery plan, in the quality right stuff, that's the way to sell it in. I think the third point would be get people with lived experience involved from day one, you know, kind of build it in around your local context. Make sure that if you're doing something new, that this makes sense to people from user organizations, from that know this field inside out, and that have lived it themselves. A fourth point I would think would be I think we should be afraid to kind of say that we are working with kind of quite core therapeutic themes here. I think when you're talking about the ability to make your own decisions, to be in touch with your own values, with your own meanings on what you want to get out of life, that's therapy stuff. And I think we can say that quite loudly and proudly. And that's a language that I think that clinical colleagues understand, and people that are looking for support want to hear as well, perhaps. And then the final point would be implement, reassess, change, and try and spread it as much as possible. We've had a bit of a model where I've brought in observers to the courses that are from different backgrounds, that are from lower, from kind of more locally based teams and other organizations. So try and use your pilot project to spread the word as well.
Fantastic. Thank you so much for that, Peter. What I might do, because we're just about to run out of time, and I did want to ask Jacob's perspective on this. Again,
Sure.
Jacob, you've shared some really valuable insights. What would be your response to Michelle on this?
Well, my top 5 actions would be: number 1, have multi-stakeholder engagement. So engaging government, engaging development community, engaging the private sector, which is the world of work, where a lot of opportunities for people would naturally lie, and also get academia involved as well. Coming up with facility-based interventions within the healthcare facilities and the service providers to get them fully acquainted with this intervention and to help delivery of it from the facility. Implementing it within the community would be my number 3. Getting the community involved as widely as possible. So the service users themselves, their family members, and other community stakeholders. Then empowering the service users through networking and support groups, so linkages to different services, so that there's always that unity and collaboration among service users and people with lived experience. And one thing I'm passionate about and also working on in Zimbabwe with the different stakeholders is building a national database of people with lived experience. So within that database, we'll be able to monitor how much progress is being made. And it could also be a repository for people to bank their recovery plans. Because when a crisis happens and the community is made aware and the health service providers are also aware that there is such a repository, the recovery plans can easily be pulled out. So those would be my top 5 proposals.
Fantastic. Thank you so much, Jacob. I guess I'm going to round this up before I hand over to Michelle and say that recovery, the process of recovery, it started in the social justice movement. And it was led by people with lived experience, and it came from them, it was directed by them. So this is where we really need to come back to the beginning and the end and the middle, is people with lived experience. This is their plan. It's for their care, and it's directed by them. So whatever we do, it should come back to that at the end. And Michelle, I wonder whether you would mind summarizing for us. Thank you so much.
Well, I'm not going to summarize, because I think it's been very rich, and we are coming to an end. But I did just want to thank everyone. Greg, I want to thank you very much for moderating this session. It was fantastic. I think we had 129 in the beginning, and we've got 120 people still with us. So that's pretty good for a 90-minute session where, so many people are very busy. So, I think that's testament to the fact that this has been really engaging and helpful for people. I hope that is correct. So thank you so much, Greg, for moderating that. And of course, thank you so much to our speakers, Peter, Jan, Jacob, Alexi. It was absolutely fabulous to hear your insights and have your contributions and experiences. Of course, thank you to everyone for joining this webinar. And please do mark your calendars for the next webinar, because it is on supported decision making and it's scheduled for the 19th of June at 3 to 4:30 CES, so same timeline as now, European summertime. And the difference for this webinar is that it's going to be interpreted, it's going to have simultaneous interpretation in English and Spanish as well. So we're really grateful for that. And it's a Catalonia government that's supporting the webinar. Just want to draw your attention to the resources that Natalie is putting into the chat or has put into the chat around the Quality Rights e-training, which we've mentioned, and some other resources, I think. So please do take a look at them if you are not already familiar with them. And yeah, thank you all once again for your contributions, your engagement and enthusiasm. Thank you so much.
Thank you very much, everyone. Bye-bye.
Bye.
Thank you. Bye, everyone.
Bye-bye.
Bye for now.
Bye.
Bye.
Goodbye.
Thank you. Bye.
Bye, everyone. Bye.
Bye. Bye-bye.
Thank you. Bye-bye. Bye, Greg.
you.
Thank you. Bye-bye.
See you again.
Oh.
I end the session.
Well, let's just see.
who's
Huh?
Yeah.
Yeah. Well, I think
you can stop the recording, John.
yeah, that's for sure.